My name is Tito and I'm a community orthopedic surgeon about 2.5 hours west up in the mountains. And I've been asked by Tetris to kind of go over my experience. So in my search for biologic augmentation of cuff tendon repairs, kind of gone on for almost 20 years. Initially, it was trying to make a mechanical injury to the tendon to bring in some blood supply. So poking holes in the tendon. PRP became commercially available. We injected that into the puncture wounds. We also injected that around our tendon repairs, hoping for improved response. Over time, we developed a stable membrane to pull underneath our rotator cuff repairs and hold it there while we fixed our tendons. We transitioned to a DBM strip soaked in PRP and later on added bursal cells for their mesenchymal stem cell properties. And last year at this meeting, I saw NFix RC and now the TAC-T and made a basic switch. And why NFix? Mazoka in 2017 talked to me and a few others here in Denver about DBM demonstrating regeneration of that physiologic enthesis rather than disorganized fibrovascular scar. And we know that that scar, when rotator cuff heals, can stretch, it's weak, and it's prone to failure. So I was interested in creating a technique for better bone to tendon healing that was simple enough to use on a routine basis and improved my healing rates and patient outcomes. We developed a technique using a DBM strip, but I wanted a better, simpler solution. And therefore, Tetris came about last year, and that was a game changer for me. At the rotator cuff, the repair techniques focus on secure attachment of tendon to bone using sutures and bone anchors. You can see all our reps out here with many different ways to put the tendon down. But they've not been effective in promoting that regeneration of the native enthesis. Therefore, the mechanical properties of the fibrovascular scar tissue that forms at the interface don't approximate those of normal tendon enthesis. Failure to recreate that structure and mechanics of the healthy enthesis can predispose the repair site to failure in continuity, gapping, or frank rupture. And the slides that you see are basically a sheep study that shows formation of that enthesis. A rabbit infraspinatus study also showed that in implantation and then cutting suture and doing mechanical studies, we saw both at 6 weeks and at 12 weeks increasing strength of that tendon to bone healing compared to control. Back in 2019, we were commercially available bone matrix strip that was quite large, and we figured out a technique. We'd find my medial row, put in anchors, measure the size, cut that graft that had been soaking in PRP to size, and then using a pulley technique, bring it down into bone. This was time consuming. It took, even after doing a few hundred, down to about 15 minutes extra time. It was wasteful because the size that made sense to match the tuberosity was 15 by 40. So we would routinely use a 20 to 25 millimeter graft. The tissue quality was highly variable. Some strips would just frankly fall apart. It was technically challenging, even for me doing a lot of those and passing the graft, and as well as securing that graft to the tuberosity. The NFix experience, we've done 30 plus cases since October of last year. Initially used the RC with anchors, and now I'm using the TAC-T, more mimicking that DBM strip that we were using. It takes literally 1 to 2 minutes to implant. It's as simple as placing your anchor. It's not technically challenging, and the instrumentation's reusable, and as far as our community hospital is concerned, reimbursement is pretty straightforward. It's an implant, and it's covered under Medicare under the normal rotator cuff repair CPT code of 29827. So you have the TAC-O and the TAC-T. We basically designed to independently use these independent of your anchors, prepare your tuberosity, place your medial row, and then you have options as to size and area that these anchors will cover. So in the first 30 plus cases since October, we've had no adverse reactions. Our MRIs done trying to do them at 6 months post-op is showing excellent healing with a robust tendon appearance. The instrumentation and insertion does require a slightly larger lateral incision. The awl or inserter must be truly perpendicular to that tuberosity. My incision is parallel to the deltoid fibers for the TAC-T placement, and the TAC-T is put in perpendicular to the way you want it to go in. Once it's underneath the deltoid, it's easily twistable to be brought in to lay across that tuberosity. The graft can be a little bit delicate, so don't mess with it after it's been implanted, and have all of your preparation done for your speed bridge, so that all you need to do once the implant's implanted is then proceed to your lateral row fixation. The early clinical data looks very promising. Follow-up studies are underway for both the NFIX RC and the TAC. We see impressive healing at the bone-tendon interface, as you see here on the 6-month post-op MRI. There's no evidence of scarring. We see a thicker tendon and remodeling of the bone around the suture anchor. And as Nick said, there's no excessive edema or bone cyst formation. There's a current study undergoing in Australia where they're retrospectively reviewing, prospectively collect data. They're looking at 15 patients per group initially, augmented with the RC and non-augmented. The arthroscopic repair of massive cuff tears, the standard non-contrast MRI is done pre-op and then 6 months post-op. At 6 months, the non-contrast MRI are showing a much better healing type with 83% of Sugaya type 2 repair integrity compared to 53% in the non-augmented group. Average tendon thickness is 5 millimeters compared to 4.3 with the non-augmented group. The clinical outcome scores are no difference between the two treatment types. So findings, and we noted improvement in tendon thickness and quality following augmentation with DBF implant. The clinical outcomes are similar to those without augmentation, but we need a lot more follow-up and a lot more patients, but the early data is very encouraging. So in summary, bone to tendon repair is an acknowledged clinical need. We heal the bone to the tendon, directly addressing enthesis failure syndrome with a new approach as opposed to an over the tendon approach, which doesn't really address the true biology or blood supply of a rotator cuff or any tendon for that fact healing. The product's 100% bone allograft that has a proven history as best-in-class biologic graft solution. The Tetris approach to enthesis healing has strong scientific proof via preclinical studies and early clinical data. The reimbursement landscape is understood, and over 175 cases with now over 350 implants since July of 23 are proving that. And it's a simple technique, adding a robust biologic advantage that is as quick and easy as placing an anchor and answering what we need for tendon healing. Thank you.